Hello and welcome to the CCO Infectious Disease Podcast. I'm your host, Zachary Schwartz. In today's episode, we continue our exploration of the current Mpox outbreak. In this episode, we examine who's at risk, and we explore some of the more vexing questions about how to reach those at risk and how to implement vaccination. To learn more about the basics of Mpox, see the link to our accompanying text module in the show notes, and to get access to all of our podcasts, subscribe to the CCO Infectious Disease channel in your favorite podcast service. Again, today I'm joined by Dr. Carlos Del Rio from Emory University School of Medicine in Atlanta and Dr. Aniruddha Hazra from University of Chicago. So let's start our discussion. Dr. Del Rio, who is most at risk for Mpox? Who are the people who would benefit the most from vaccination?
So when we think about who's at highest risk of Mpox during this current 2022 outbreak, it is really a man, and specifically men who have sex with men who have multiple partners. Those are at highest risk of Mpox. And, close to over 90% of the cases have been among men and men who have sex with men. So that really is the highest risk. That doesn't mean that you don't see cases in women. You do, but they're small. And you also can see occasionally cases in children. Now, that's a little different than what happens in Africa, right? In Africa, most cases have been among children under 15 years of age. But outside of Africa, it appears to be more common in men who have sex with men. So really is different depending on what the setting is and what the transmission dynamics are.
Yeah, and I think what we're noticing with this current outbreak has been really the close, sustained, direct contact with lesions, which really equates to person-to-person transmission. So not just casual contact, not just being around someone in some sort of setting, but it's really prolonged close contact with potential lesions or skin rashes that someone may have who has Mpox as a way to transmit it to others.
Yeah, and I think that's really important, right? That it's really is that sustained contact with infected lesions that leads to transmission. So living with somebody or just casual contact is not necessarily how this disease is going to spread.
Yeah, because there's a lot of concerns about, if I'm at an outdoor festival and someone has Mpox, can I get it? And, just having just that type of short-term contact with someone and whatnot, that's not really how we see at least, Mpox been transmitted in this outbreak for the past 2 years now.
So let me ask you, do we see Mpox, the current outbreak, the 2022 outbreak, the one we're just talking about, should we call it an STI? Is that something, at the beginning, I wasn't totally convinced, but I changed my mind. And, I think there's pros and cons of doing that, right?
Yeah. I think that's been a question that's been posed since the onset of the outbreak when we started noticing sort of Mpox specifically in gay, bisexual men, obsessed with men, is trying to sort of think about, is this considered an STI? I think there's clear evidence, like irrefutable evidence, that Mpox is sexually transmitted, that Mpox can be transmitted human to human through sexual contact and intimate contact for sure. I think the nuance of calling it now fully an STI versus not STI, I think really depends on what your feelings are about this. I think there are plenty of infections that we know can be sexually transmitted, but we don't classify them as STIs, and vice versa. There's plenty of STIs that can be transmitted other ways, but are classified as sexually transmitted infections. I think the pros of classifying Mpox as a STI clearly come from, a funding perspective of being able to potentially utilize other sources of investment we have towards STIs, towards sort of Mpox disease itself. But I do think there's a nuance there to understand that Mpox still affects other people through non-sexual transmission. And, throughout its global history over the past half century was not sexually transmitted. So suddenly classifying Mpox as an STI solely because of the way it's maybe acting in this current outbreak may be sort of somewhat erasing or smudging the history that Mpox has in these other areas of endemicity.
Yeah, no, I agree with you. I'm tell people that Mpox can be sexually transmitted, is sexually transmitted, but that doesn't mean it's a sexually transmitted infection in the classic sense of the STIs, right?
Yeah,
because of the stigma and the many other issues that are associated with sexually transmitted infections. But I tell you, there was a lot of stigma associated with just being told you had Mpox. And, in fact, we don't say it right now, but we used to even call this monkeypox rather than not Mpox, right?
Right. No, for sure. And I think, changing the name itself by the WHO, I think was a nod to the community. I think because of the community, it was, from the community thinking about, the name matters and how we're thinking about it totally matters itself. I got to say, Carlos, I think the CDC has actually done a really great job throughout the Mpox outbreak. I think their messaging was really on point. They really threaded the needle around, is this an STI? Is this not an STI? what populations are most disproportionately impacted versus we see Mpox in all populations, but our priority populations are, the folks that we've talked about. They have created a great toolkit that they have continued to actually update year to year on thinking about how to promote, vaccine uptake and how you as a, healthcare organization or a CBO can really think about implementing Mpox vaccines in your own practice.
Yeah, no, without doubt. But I tell you, yeah, CDC has done a great job. But honestly, Dimitri has done a great job. It was really the leadership of Dimitri Deskalakis that really allowed us to have an incredible response. And I think that a lot of credit. I mean, CDC deserves the credit, but boy, it's Dimitri that really is, the way he approached this, the way he went after it is just something. It was unique and something that honestly I'm very impressed and very thankful for his work, the work he did at the White House, etc. I mean, he really, when he was named, the sort of the Mpox czar, if he went to the White House to work on things, I think really was not only it was a response from the CDC, quite frankly, it was a response from the entire federal government in really addressing this in an effective way. And again, showing how important leadership is and how important good leadership is in addressing a disease like this one. CDC has continued to do things. They have a sort of a toolkit, right, that allows us to get this to event organizers, to organizations, to bars. It tells you, what can you do? It helps you with messaging. It's a good toolkit to have available if you're interested in knowing how to get the vaccine. If you're having an event, how to get the vaccine to the right people at the right time at the right place, and how to get this done. And I would encourage people to take a look at it.
Yeah, it helps people from not having to reinvent the wheel and not have to start from scratch. So they can start from these materials and be able to develop maybe more community focused or maybe more focused to their populations or their groups from there.
For sure, absolutely. What is the advice that we're telling people about getting the vaccine with something else?
Yeah, so I think that ACIP really recommends that you can receive the vaccine with sort of any other vaccine doses. There's no need to space out other vaccines with the MVA-BN vaccine itself. And that's what we were doing in our practice. So if people were eligible for, other preventative vaccines like HPV or hepatitis B or whatnot, we were providing those at the same time as the MVA-BN vaccine.
Yeah, we were doing the same thing. In some patients, you would consider spacing them and saying, okay, we'll give you your vaccine now, and then we'll give you your COVID vaccine later. But at the end of the day, it really it was more out of what the patients wanted than anything else.
Yeah, and I mean it's difficult because oftentimes you have a small window of opportunity to act in that clinic or in that exam room, and so if you have someone in front of you that's ready and willing to get vaccinated, I try to do as much as I can for them that they feel comfortable with.
The great majority of severe disease and deaths we saw in our country were people who had HIV and who were not in care, either newly diagnosed with HIV or HIV who are not in care, who are not receiving antiretroviral therapy, and who are not virally suppressed. And unfortunately, a lot of those persons who were African American, were poor, were minorities. So the disproportionate impact of this disease in minority populations is something that continues to plague us as a country. We continue to see how diseases like Mpox just exacerbate health disparities and really find their way into those. So I go back to saying that addressing and decreasing a disease like Mpox, it starts by providing health equity, and vaccination is a way to provide health equity. One of my former bosses, who was a sort of a champion of immunization, used to say that by vaccinating children, he talked about you're giving kids what he called immunological equity. And I love that phrase because quite frankly, that is equity is at the center of addressing this epidemics and this pandemics and this disproportionate impact. And the fact is that we should not have seen the mortality we saw if we really took care of people appropriately in our country.
Yeah, I mean, I think, Mpox, like any other communicable disease that we've seen throughout our history, tracks along racial and socioeconomic fault lines. And, when you actually plot out sort of even who is getting vaccine in this country and who is getting Mpox in this country, you're seeing that same disparities as we are with the PrEP to need ratios we're seeing in the US as well. The folks that need Mpox vaccine the most are the ones that are least likely to receive it. And why is that? That's due to systemic barriers and systemic social and structural determinants of health that are impacting the ability for folks to come in and get vaccinated, whether that is the logistical of coming into the clinic to get vaccinated, or just the hesitancy or the lack of access to education around vaccination or understanding their own vulnerability to Mpox. I think all the more reason, so much of the community-based work was successful in major cities throughout 2022 is really trying to bring vaccination to the people, bring education in a way that, is well understood and is received by communities that are most vulnerable to Mpox. But there's still so much work to be done. I think we're still seeing about 200 cases of Mpox on a monthly basis in the United States here, that's suggesting that is it becoming endemic here? And again, still disproportionately impacting Black and other minoritized populations across the US, who again are the least likely to be vaccinated at this time due to a multitude of social, structural, individual reasons.
Yeah, so it just goes back to, the best vaccine is health equity, right? If we work on health equity, we will be able to control diseases like Mpox. And it's not just a matter of having a vaccine. You got to get it to the most vulnerable populations, and you got to get them vaccinated, because at the end of the day, vaccines don't work, vaccination works, and you got to get vaccination to people, right?
Exactly. Just the implementation itself, I think, is the most important. So really recognizing, and speaking with community advisory boards or speaking with communities that you serve to see how can you best get the messaging out to them, and how can you deliver the vaccines to them in a way that they would receive it is, I think, the most critical.
For sure. Absolutely.
So we've discussed how vaccination for Mpox is especially important for vulnerable groups based on sexual activity, for example. But we also know that in this outbreak, many people infected were also living with HIV. Can you tell us more about the intersection of Mpox and HIV?
So Mpox has not gone away. It's certainly not, impacting to the same degree that we saw 2 years ago, but still, around. And again, trying to make sure that we are able to offer folks the ability to protect themselves effectively is all the more important. I think what we're seeing in general is a disproportionate number of Mpox cases in people living with HIV. And that continues to be my most highest prioritized population. And I don't know, Carlos, if that's something that you've been, prioritizing as well. But, we go through our list of folks living with HIV who are not vaccinated for Mpox and continue to do outreach across that list to make sure that they have access to vaccination. Just because, again, the morbidity that we've seen with Mpox has all really been in folks not only living with HIV, but those with advanced HIV.
Absolutely. And again, it's how we have to really be out there, and it goes back to, I hate to say it, it goes back to basics. You have to test people for HIV because, as you said, many are newly diagnosed with HIV. Test people with HIV, get people with HIV into care, link them to care, start a trial, getting them suppressed. It's going back to how do we improve our cascade of care for HIV? That's at the end of the day what we continue to do. And because again, as a country, we're not doing very well in our HIV response and our cascade of care. The number of persons living with HIV who are virally suppressed is still right around 67%. We need to do better than that. So I think this is another opportunity to work on engagement and care as a way to address the HIV epidemic.
Entirely.
Well, thank you to Dr. Del Rio and to Dr. Hazra, and thank you to our listeners for joining in. You can learn more about Mpox at the CCO website. Just click on the link in the show notes. Thanks again, and we'll see you on the next webinar soon.